I'm Corrigall from South Africa. I'm a public health specialist and I've worked in both government and international NGOs for at least about 12 years now, working in public health projects. And a lot of it, in fact, has had to do with prevention. So I have a lot of examples I can share with you in this lecture. And today's lecture, as you can see from the title, is the natural history of diseases and levels of prevention. So just a quick overview of the lecture. We'll start off just having a look at what actually epidemiology is. We'll then go to the natural history of disease, which has different stages that we'll go through. And part of the description of the natural history of diseases will also cover an approach to risk factors and how to think about risk from an epidemiological and public health approach. We'll have a look at a few of the applications of this knowledge. And then we'll look at one of the specific applications, which is prevention of diseases. And much like the natural history of disease, there are different levels and different types of prevention. So we'll be going through those as well. And as you'll see, they very much relate to the different stages of the natural history of disease. So let's begin by first having a look at what is epidemiology. So the official definition is that it's the study of the frequency, distribution, and determinants of diseases and other health-related conditions, such as injuries, for example, in human populations, and the application of the study to the promotion of health, the prevention, and control of health problems. So let's just break that down a little bit. If we look at frequency, so we've said it's the study of the frequency of disease. So what is frequency? It's really just how common is a disease. So an example might be the HIV positivity rate in South Africa. So here the prevalence of HIV is 20%. Other frequency measures would include morbidity rates and mortality rates, which refer to essentially death rates and the amount of population living with disease. Then let's have a look at the words distribution. So it's the study of the distribution of diseases. So distribution really refers to how a disease is spread amongst the population. So you have different population groups, obviously, and there are certain diseases which are more common in men or women, and then some also relate to age groups. So for some diseases, for example, violence, alcohol abuse, there we find that the population most affected and at highest risk are young men. And with other diseases, it's different. So for example, with HIV, it's more women who are at risk. So what are the and then the other element of epidemiology is the study of the determinants of diseases. So this really relates to what are the risk factors and the causative agents, and we'll go into that a little bit more when we're going through the natural history of diseases. And then the other point that I just wanted to point out here is that unlike clinical medicine, with public health, the focus of epidemiology and all of the interventions is really the effect of disease on the population rather than individuals. So we look at the effects and impact of disease and prevention of disease at a population level. So we can pull out from the definition of epidemiology two elements that we're going to be looking at today. One of them relates to the determinants of disease, which is connected to the natural history of disease. And then the other element we're looking at today is the prevention of disease, given our knowledge of the natural history of disease. So let's begin now with the natural history of disease. So again, our official definition is that it's a description of the uninterrupted progression of a disease in an individual from the moment of exposure to the causal agents until recovery or death. So if we think about it just very simply, what this really refers to is the progress of a disease in an individual over time without any treatment. So again, one can just break the words down. It's natural, so there's no intervention or treatment, and it's history. Essentially, it's like what happens to this person if they get this disease without any treatment. So let's have a look at the different stages of a disease. First, we have the stage of susceptibility. So now this is the stage where the person isn't infected but at risk. Then we have the stage of subclinical disease, where they're infected but there's no symptoms. Clinical disease, they have symptoms. And then finally, we have the stage of recovery, disability, or death, so the outcome of the disease. So we're going to look at those now each in turn in a little bit more detail. So stage 1, susceptibility. In this stage, there is no disease yet, but the process is now beginning with exposure to accumulation of a number of risk factors that are then sufficient for the disease process to begin. So what does that mean? It means that sometimes one risk factor alone is not sufficient for the person to get the disease, but they need a combination of factors. So for example, not everybody who is exposed to HIV will necessarily become infected with it. It depends, for example, on their nutritional status, whether or not there's STDs present, and a number of other factors. So really at this point, we're looking at what are the risk factors involved here. So one of the oldest and most well-known ways of thinking about risk is looking at the epidemiological triad. So this triad refers to three factors that really influence disease. The first is the agent. So this refers to either an infectious agent or a toxin. So it might be, for example, in malaria, the Plasmodium falciparum and the mosquito, or in the case of lung cancer, for example, it might be cigarette smoke as the toxin. Then we have host factors. So this refers to the person who's actually becoming diseased, and it refers to intrinsic factors about them that influence their exposure, susceptibility, or response to a causative agent. So in an example here, we could say the condom usage, for example, would be a host factor that would infect their susceptibility to being infected when exposed. And then lastly, we have the environmental factors. So these are extrinsic factors which affect the agent and the opportunity for exposure. So in the example of malaria, it might be, for example, climate. So we know that you're much more likely to get malaria when it's a warm and rainy season, because then that allows for the reproduction of mosquitoes that spread the parasite. But there's many ways of looking at risk, and so nowadays there's also, there's different models, and in particular there's a model that we're going to look at now, which takes a much more detailed look. So the important thing to remember here is not to get confused. They're different models, but really they're referring to the same thing. It's just different ways of looking at the same thing. So let's just look at risk factors, okay? If we define a risk factor, what is it? It's really any attribute, characteristic, or exposure of an individual that increases the likelihood of developing a disease or injury. So really it's something that increases the likelihood or chances of getting a disease. So they can occur at many levels, and the ecological model is a model that is very good at describing the different levels of risk factors and therefore the different levels at which one can intervene. And so how this came about is that it's based on the evidence that no single factor can explain why some people or groups are at higher risk of certain diseases while others are more protected. So that this particular framework views disease or injury as the outcome of interaction among many factors at 4 levels. And instead of explaining it in an abstract way, I thought it would be much easier to understand to show you an example. So I've worked quite a lot on violence prevention, and this in fact was a model that we came up with for trying to determine what preventative measures we could take to reduce violence in South Africa. So if we look now at the individual level, this would now be factors relating to a particular person. So it might be a biological or psychological factor. In this instance, we can say the person might have an alcohol addiction, or they're a binge drinker. They might have a psychological or personality disorder as examples. Then we look just beyond that individual at the relationships that they're having within their family and their very close social network. So here, they might be having marital problems. They might be experiencing conflict within their household. Or they might be friends with people for whom violence is considered normal and appropriate response to conflicts. Then we, again, go a little bit further out from that individual and look at the community. So this is now people that they might not necessarily know, but people that are living around them. And this is important because often it sets in place norms and kind of behavior patterns that influence somebody at an individual level. So here, if they're living in a neighborhood where there's lots of poverty, there's high crime level, a lot of unemployment, we know that those people in that neighborhood are much more at risk for violent behavior or experiencing violence. Then again, we take another step further out and we look at the society as a whole. So now this would be, in the case of South Africa, not just the neighborhood somebody lives in, but the entire framework of South Africa in terms of its laws, in terms of its norms. So examples here might be, we have poor policing. So, you know, when a violence breaks out, it takes a long time for the police to get there. Maybe they don't always respond in the same way. And factors like that can make a difference. Another example would be alcohol laws. So if alcohol is easily accessible all the time, we know that people are much greater risk for either being a victim or a perpetrator of violence. So you can see now with this kind of model that it's really taking risk and breaking it down into its really detailed aspects. And you can see how having this knowledge enables you to target different aspects for prevention. All right, then let's have a look now at the subclinical stage. So now this stage here is when the person has been exposed or they've been infected, in the case of infectious diseases. And now you don't see symptoms or pathological changes, but the person is infected. So a good example of that would be somebody who's HIV positive, but they haven't got any symptoms. It could be a precancerous mole, high cholesterol. So here, there are no manifestations of the disease, but pathological changes have started to occur. At this point, the disease can usually only be detected through special tests because the signs and symptoms are not apparent. So this stage extends from the time of exposure to the onset of symptoms. And this time, in the case of infectious diseases, is called the incubation period. And in terms of more chronic diseases, it would be called the latency period. So an example of a chronic disease would be something like lung cancer. So you might be smoking for 20 years before you develop lung cancer, and that period from which you start to have biological changes in the lungs up until when you become symptomatic would be the latency period. And so this period can be brief, seconds in terms of an allergic reaction, or it could be decades, as with the example of lung cancer. And just important to note here that not every disease that is subclinical necessarily leads to the clinical stage or disease. So many people are infected with a disease and they never become symptomatic. So there are certain types of hepatitis in which that's the case. Even sometimes with flu, I think we've all had that experience when you can feel that you're infected, but you don't actually develop flu if you rest and you take your vitamin C and do all of those kinds of things. So it's important to remember this because there can also be people here who can infect others during that stage. So we really need to know that this is part of the natural history of disease. Okay, so diseases that have long incubation periods usually have a long clinical course, and then they're called chronic diseases. So a good example here would now be something like HIV. We know that you can be infected with HIV and you can be asymptomatic for a decade or even longer. And now with treatments available, this disease takes a very long time to cause death or disability and morbidity. So HIV has come to be seen as a chronic disease. Other examples that are non-infectious would be your cancers, your chronic diseases like cardiovascular diseases, stroke, etc. So those diseases take a long time to develop, but then they really have a very long course as well. Usually they're for people's lifetime. But it can be, for example, in cancer, once you've had treatment, that can be cured. But again, if we think of it in terms of natural history, if there wasn't treatment, it would go on for quite a long time until the person passed away. Then you have other diseases with a very short incubation period, and these also normally have short course. So in other words, they don't last very long. And these diseases are normally called acute diseases. So here, for example, one could think about flu, one could think about meningitis, malaria. So there's many examples of acute diseases. And again, you know, if you think about how is this information useful, if you're planning your health services, you want to know, okay, if we have this many people who are infected by this kind of disease, if they're going to be sick for another 30, 40 years, we need to plan our services around that. So this is very important, especially with the increase that we see now in chronic diseases, such as the cardiovascular diseases, diabetes, and HIV in South Africa is a very important chronic disease here. And so a lot of money goes into health services to provide ongoing treatment as outpatients for a lot of people. And this is a shift that we're seeing in many so-called developing countries, that we're seeing chronic diseases overtaking acute diseases, which has a significant impact for health planners and obviously prevention work as well. Okay, then let's have a look now at stage 3. So this is now the stage that most people are familiar with when they think of a disease. And that's the stage where the person now has symptoms. And you'll notice here that the time of diagnosis is there's usually a gap between the onset of symptoms and diagnosis. And you'll see when we talk about prevention that this is one of the areas that we try and address to try and make that gap as narrow as possible. And the reason for that is obviously to try and give the person who's infected by the disease or affected by the disease the best chance possible for a positive outcome. And normally that goes hand in hand with early treatment. So at this stage, the person starts getting signs and symptoms of the disease. And again, in every different kind of disease or injury, they can differ in duration, severity, and outcome. So if you can for yourself think of some examples, what would be an illness that has a very short duration? What would be an illness that has a very long duration? So we can think the shortest duration. I've put a picture here of a lady who she's having an allergy at the beginning of spring to pollens that are in the air, and so that will last normally, depending on the summer season, it can last sometimes just a couple of weeks and then it goes away. A longer duration illness would be more of your chronic diseases that we've already discussed. And obviously a lot of the mental health illnesses also have quite a long duration. So for example, schizophrenia is an illness that will last a lifetime. And then common mental illnesses like depression will have a chronic course, but there'll be interruptions. So for example, somebody will have an episode of depression, then they'll go into a period of recovery, but we know that in most of the cases they'll have another episode of depression later. And so because of this chronic nature, chronic recurring nature of the disease, normally these people are put on chronic medication and require constant follow-up at outpatients. So then if you think of examples of severity, a mild illness, well, the commonest one is probably flu or influenza, and then a severe illness would be something like pancreatic cancer, for which it's very difficult to treat people, and it's a long course of treatment. And then different types of outcomes. Obviously, some illnesses you recover from, and some you land up disabled, and others death. But we'll have a look at that more when we get to that part of the natural history of disease. So the outcome of the disease is the last stage, and here one can have recovery. So that can either be spontaneously, in other words, without treatment, or it can be as a result of treatment. Many illnesses recover on their own. They might just take a little bit longer. So chest infection, could go on, for example, for 8 weeks without treatment, but with treatment it might be reduced to 4 weeks or 3 weeks. Disability can be temporary, or it can be permanent. So for example, if somebody tears a ligament in their ankle, they might not be able to walk for several weeks, but then soon enough it will recover. Can also be permanent, in other words, something that will not heal. So that might be in the case of polio, when somebody is unable to use their legs properly ever again. It can be partial disability, which refers to just one part of the person's body, or it can be complete in the case of a severe head injury and the person is paralyzed. And obviously the last possible outcome is death. So here are just some pictures of somebody who's recovered, somebody who's died, and this picture actually comes from Ghana. It's a picture of a funeral in Ghana. And then here is a picture of somebody who's clearly got a permanent disability, who, I don't know what the case was in this person, but polio is something that is really injured people a lot, and injuries in Africa are also something that has permanently disabled a lot of people, where, for example, they might have had their legs blown off in warfare and such. So let's now take an example looking at the entire natural history of a particular disease. I've chosen HIV because it's something that everybody knows a little bit about, so hopefully you're familiar with the disease. So first we have the susceptibility period, and so that would be to the left of this red line and where the arrow is pointing. So at this stage, the person's not infected, and there are just possible risk factors that they're being exposed to. Then we have the subclinical or incubation period. So this happens between both of these red lines. So it's from infection to before the person develops clinical disease. In the case of HIV, when you first get infected, you might have a flu-like symptoms, which we call acute retroviral syndrome. But that really doesn't last very long. As you can see, it's quite a brief period. And then the person is completely asymptomatic. And also not everybody gets these flu-like symptoms. So you can see that for a long time, up to 7 years, people can remain completely asymptomatic. And clearly this is important because we know that during this period they can obviously spread the disease. So this is why we have programs that promote testing, even if somebody is asymptomatic. Then we have the clinical stage, which is now when the person develops AIDS. So here are some examples for HIV would be lymph node enlargement, fever, weight loss. A lot of opportunistic infections arrive at that time. In South Africa, we see a lot of TB around this stage. Tumors, cancer starts developing as immunity drops. And so this now describes the clinical component of the natural history of HIV. And then at some point, the person dies, usually from one of these diseases. So this is now the natural history without any treatment. So you can see that here, the natural history, the person will probably live, let's say, 11 years from the time of infection. Obviously now when you add treatment, it changes things. And we know that nowadays with proper treatments and care, that people can actually live as long as anybody else with HIV. And that's because we've been able to intervene at all these different stages. Okay, so some of the applications of the natural history of diseases is that, as you can see, it's really vital information when you start thinking about designing disease prevention and interventions at your population level. It also helps you plan healthcare. So you need to know what proportion of people will be at what stage, and therefore you're able to know what type of services you need to provide, where you need to provide, who your target groups are for that provision. The purpose of healthcare, including medicine, is of course to influence the natural history of disease by reducing and delaying ill health. So as I showed you in the last example, you can see with HIV, the natural history really gives somebody approximately 11 years. But now with treatment, you can see that we've had a major impact in both reducing and delaying ill health. And when achieved through the deliberate actions by societies, this collective endeavor of trying to delay and reduce ill health through prevention, we call this endeavor public health. Okay, so now we're going to have a look at prevention. And disease prevention refers to actions taken to prevent the occurrence of disease, such as risk factor reduction, but it's also about preventing the progress of a disease and to reduce its consequences once the disease is established. So that sounds like a mouthful now, but we're going to be breaking it down and looking at each of those elements. So don't be alarmed if that seems like a lot to take in. So let's look at our natural history. And as you can see, as we've gone through it, it's very easy to use this information to plan and design interventions for prevention. So it helps us to prevent exposure to risk factors, exposure to infectious agents and toxins. It helps us prevent the progression of disease from subclinical to clinical, the spread of disease. It helps us prevent complications, and it helps us slow down or reduce and even ideally prevent death and disability from that particular disease. Obviously, we can't prevent death completely because that is a fact of life. All right, so the levels of prevention, you'll hear the terms primary, secondary, and tertiary prevention quite a lot. And these were first documented in the late 1940s by Hugh Lavelle and E. Gurney Clark from Harvard and Columbia University Schools of Public Health. So it's quite amazing that this framework developed in the 1940s is still being used today. And as you'll see, it's been elaborated on a little bit, but really it's much the same as they conceptualized it. And it's had a major impact in controlling many of the diseases that have affected humanity. So let's take a look now. What do these different levels actually refer to? So I'm going to bring you back to our natural history of disease. And you'll see as we go through this, the different levels of prevention pretty much speak to these different stages. However, there's been an additional stage added in over here, which is actually trying to prevent the risk factors themselves. So let's have a look what that means. So this particular stage is called primordial prevention. So primordial happens before primary. What is it? So primordial prevention consists of actions to minimize future hazards to health and hence inhibit the establishment of risk factors, which are known to increase the risk of disease. So these factors might be environmental, economic, social, behavioral, or cultural, and it addresses broad health determinants rather than preventing specific diseases. So let's think about this in terms of examples, because it's a lot easier to understand when we think of examples. So one good example would be improving sanitation. Now this kind of intervention is not specific to the elimination of any particular disease or outcome, and in fact will have multiple positive health outcomes. So it would affect many causes of diarrhea, for example. It can also prevent exposure to toxins that can come through water that isn't properly managed. So you can see it's not specific to one disease, and it's quite a general broad health determinant, having proper sanitation. Another example would be exercise, sports, or dance programs in schools. Again, this is an intervention that will have a positive effect on multiple health outcomes. So it reduces risks for cardiovascular disease, it improves mental health, and you can see that really there's a number of disease outcomes that this kind of program could really benefit children. Another really fantastic example is early childhood development programs. So these programs really focus on stimulating young children under the age of 5, both socially, mentally, psychologically. So it's about trying to learn cognitive skills, social skills, and also builds muscle skills. And what the evidence has shown, that even up to 20 years after a good early childhood development programs, those who were in good programs had much lower chances of being unemployed, of developing mental health problems, of being involved in violence, reduced rates of substance abuse. So this is something that is a very powerful intervention with multiple positive health outcomes. Another example would, of course, be gender equality programs. This affects mothers' ability to actually mother their own children. So it affects the health of not just them, but also their children. It reduces the incidence of domestic violence. It improves reproductive health. So again, an intervention with multiple positive health outcomes. So the aim of primordial prevention is to achieve health. So what is health actually? Let's think about this, because we often know a lot about disease, but oftentimes not that much about health. And health is really our aim here. And what is health? It's a state of complete physical, mental, and social well-being, and is not merely the absence of disease or infirmity. So now let's have a quick look at primary prevention. Okay, so primary prevention happens at the stage of susceptibility. So if you remember from before, this is the stage where people are not yet infected or haven't yet been infected by the disease or the agent. So this is the stage of risk. So what primary prevention does is it seeks to prevent the onset of specific diseases, and this is how it differs from primordial prevention. So it prevents the onset of specific diseases or injuries via risk reduction. So now the risks are already there. So that would be really a failure of primordial prevention. We have risks that are there, and now we're just trying to prevent the person from being exposed to these risks. How do we do this? By altering behaviors or exposures that can lead to disease, or by enhancing resistance to the effects of exposure to a disease agent. So there's several components. There's health promotion, prevention from exposure, and disease prevention. So let's have a look at a few examples of that. So vaccinations would be preventing the disease, because the idea here is that when you're exposed to the infectious agent, the vaccination will give you immunity so that you can resist the disease. And an example of exposure prevention would be condom usage in the case of HIV. So again, you're not preventing the person from being exposed to the virus, but you're preventing that virus from entering their body, and therefore you're preventing the exposure to their body. So they're being exposed to it, but they're not being infected by it. The third example would be economic programs for women. And again, when I spoke about the gender empowerment programs, this is something that could be a form of primary prevention for a specific disease. So for example, in the case of domestic violence, this could be an example of what you might do under primary prevention. Another example of exposure prevention would be gun control. So here, the specific disease that we're looking at is suicides. So on the left-hand side, you'll see that this here is looking at gun laws in different states. So in the states that are very dark, those are the areas where you have the strongest gun laws, and then in the states where it's a little bit lighter, that's where the gun laws are a bit more relaxed, and so people have greater access to guns. And it's quite amazing to then have a look at the graph, the chart on the right, where we're looking at suicide rates, and what we see here is that there's really quite a close mapping between spaces where there is good gun control, where there's reduced access, and the number of suicides. And this is something we also see quite a lot with rates of violence, where access to guns, you can literally map where you're going to find higher violence related to the density of guns in that area. So take your time perhaps after the lecture and have a look at this graph, and you'll have a look to see the impacts. So how do we use causation models to design prevention? Well, we try to reduce the number of new cases of disease, and that's called the incidence. And then we also, as I said earlier, we actually make use of our causation models to think about, okay, if we want to prevent this disease, how do we go about it? So here, again, you can use whichever model is most useful for the disease that you're having a look at. So we'll have a look at both now. So in terms of violence prevention, here's an example of a strategy for prevention that is using the ecological model to design its preventive interventions. So at the individual level, to prevent youth violence, one of their interventions will be building skills with school programs to choose non-violent safe behaviors. So at the individual level, you're basically equipping people with coping skills, conflict resolution skills. So you're improving the skills of individuals. Then at the relationship levels, you're going to be working with parents so that they have their parenting skills to talk to their children, to set rules, and of course you would want them to be really demonstrating to children how to solve conflict without violence. There would also be programs to build positive relationships between young people, between other caregivers and caring adults, which might, for example, be sports teachers or the teachers at a school, could even be a pastor, depending on what the context would be. At the community level, here they want to be looking at data to see what are there any community issues that maybe need some intervention. So that might be, for example, access to recreational centers, it might be policing, they would partner with different groups across the sector. So those would be all the NGOs probably in the sector, as well as police, social workers. And then, of course, here you would also want to improve and sustain safe environments. So one of the projects I'm involved in, for example, set about putting up street lights. It's set about creating entertainment venues where there wasn't alcohol, and generally improving the infrastructure of that community. And we found a really positive effect on youth violence. And then at the societal level, they talk about changing norms related to violence and willingness to intervene when violence occurs. And so that's obviously a very important one, because if you're in a society which considers violence to be normal and acceptable, one needs to address those kinds of norms. Okay, so let's have a look now at the epidemiological triad and an example there, how one would go about prevention. So from the agent side, the agent in HIV is obviously the HIV virus itself. So one intervention here might be keeping the viral loads of HIV-positive patients low to reduce the spread of disease. So how would we do that? We make sure the people who are HIV positive are in treatment. So that way, if they do have unprotected sex with somebody, at least their viral load will be low, which might prevent that person then from becoming infected by the virus. An example under the environment, here it might be about changing sexual norms. So for example, if there's a lot of problems to do with sugar daddies, which is kind of a wealthier older man who doesn't pay for sex necessarily, but has a lot of sex with young women and then gives them money to perhaps study or to buy food, you know, that we know is a very high-risk situation for HIV, because then the woman doesn't feel empowered, and so she often accepts unprotected sexual intercourse. So there are a lot of programs that have been put in place to economically empower young women. So that would be an environmental preventative strategy. And then in terms of host factors, here, one of the examples that reduces somebody's risk of becoming infected is to be circumcised. So that would be something one does to the host themselves. While we're talking about prevention, it's important when we're thinking about primary prevention just to take note that there's two ways that one can think about primary prevention. The first can be, okay, we're going to do something that reduces the risk in the whole population. So that would be everybody, even those who are not at risk. And then the other approach would be, okay, let's just focus on the people at high risk. And neither of these is necessarily wrong or right. It very much depends on what the circumstances is, what circumstances are, what the disease in, available resources. And people have put in quite a lot of thought around, you know, which one to use and when. So I've listed a lot of the advantages and disadvantages here. I won't go through all of them, but maybe just to highlight some of them. So in terms of just targeting high-risk people, obviously what's great about this is that the intervention is very appropriate to that person. So if they're identified as high risk, what that means then is that the doctors or the nursing staff or just health workers, they feel very justified and quite motivated to try and convince this person to change their behavior. Whereas when you're looking more at a population level intervention, you know, there are a lot of people who are just not at risk. So those people, clearly the motivation for intervening with those people would be somewhat reduced. They might be changing their behavior unnecessarily. And so then people who are concerned about the ethics of interventions would say, well, is that really ethical? So an example would be reducing the trading hours of liquor outlets as a way to reduce alcohol-related violence. Now, that normally is passed at a legal level, and so it affects the entire population. Why do we do that? To reduce violence. But for example, in South Africa, most of the violence happens only in a certain number of neighborhoods. So the neighborhoods that it doesn't happen in have been complaining, well, why do we also have to suffer because of this? So, you know, those kinds of arguments do come up, and one needs to think through those kinds of things very carefully. Yeah. So just to bear that in mind, and sometimes, you know, you have to weigh up the costs and benefits, and also it's about how easy is it to implement. Will you be violating people's rights if you only target certain groups? So these questions are not simple questions and really need to be considered in detail for each situation. And then just to have a look at some of the disadvantages of the high-risk strategy. It obviously can be difficult and costly trying to identify high-risk groups, so that can be very difficult, especially at a population level. And then the other one, which I think is the most important one, is that it can have little impact on the disease burden, which is the amount of disease in society, because most cases of disease occur in people who are at low or moderate risk. So, for example, if we take something like alcohol, people often, you know, say, no, we must just focus on the alcoholics. But if you look at a population level, in terms of the numbers that are alcoholics versus the numbers that are weekend binge drinkers, there are far more binge drinkers in society than alcoholics. So if you're only focusing on alcoholics, you're not really going to be reducing alcohol-related violence or accidents from drink driving very much. All that you'll be reducing is probably the number of admissions to alcoholic units. So one needs to really think about these things very carefully. And usually what you know, my experience in policy and interventions has been that actually typically you need a combination of certain strategies that target the population. So for example, that might be reducing trading hours of liquor outlets, but also having interventions that target high-risk candidates. So that might be screening for alcohol abuse in a trauma center after people have been in a violent situation or a drunk driving accident. So what are some of the criteria for developing health promotion programs? Well, obviously, you want it to include evidence-based interventions, and there's lots of evidence on prevention. So it's quite rare that you should be really trying to come up with something that's never been done before. Obviously, one needs to try new interventions, but it's a good idea to map those with other evidence-based interventions so that you know at least there will be something you can guarantee will have some kind of impact. So the idea is that you want to reduce a targeted risk factor. You need to make sure your interventions are appropriate for the setting. So you need to take into account how much resources you have. So you don't want to have an intervention that, for example, requires heavy policing if you know that your police force is really small and don't have cars and can't actually access the space where there's violence. You need to consider the cultural norms. So every intervention needs to be culturally appropriate. What works in Brazil doesn't necessarily work in India. You need to consider sensitivities, language issues, accessibility. So again, this is something that, you know, you take the evidence and then you actually brainstorm with NGOs, with the people who are involved, with the communities that you're intending to intervene, and actually really try and figure out what's feasible, what's practical, and what's going to be your most cost-effective intervention. And then obviously I think it should go without saying that health promotion programs need to be organized, planned, and implemented. And you need to do this in a way that you can actually measure the effect of what you're doing. And that enables you to monitor what you're doing. So, you know, do you need to, if you're doing 5 interventions while you're monitoring, you might decide, okay, actually the first 2 interventions are working great, let's channel more resources towards those as opposed to the other 2. And obviously it also helps you evaluate, is what we did, has it actually reduced the risk factor that we have in mind? Okay, so let's have a quick look at secondary prevention. So here we're really trying to impact on the subclinical stage. So here it's about trying to diagnose and treat existent disease in the early stages before it causes significant morbidity. Morbidity is really illness. So you're trying to stop the progression of the disease. Secondary prevention aims to stop or slow the progression of disease so as to prevent or limit permanent damage. So it can be achieved through detecting people who already have the disease as early as possible and treat them. And obviously this is carried out before the person is permanently damaged. So a good example here would be mammography. So as a routine for breast cancer, what people often do is they start doing mammograms of women over the age of 40 to see are there any lumps in the breast that perhaps the person hasn't felt. And this has a huge impact on the prognosis for somebody who has breast cancer. Another good example are routine blood pressure checks. So checking people's blood pressure enables you to pick up the problem quickly before hypertension has set in and before people develop cardiovascular disease or stroke. So there are two components of secondary prevention. One is the early detection and the screening, and then the second one is effective and early treatment. So remember that gap that I spoke about between the onset of symptoms and the diagnosis. Here it's about trying to reduce that gap. So it's concerned with decreasing prevalence of a disease, and prevalence is really the measurement of all the people affected by the disease at a particular time. So that's different to incidence, which is what we looked at under primary prevention. Incidence is the number of new cases, whereas prevalence is just the number of people in the population at any point in time who are affected by that disease. Okay, so then let's have a look at tertiary prevention, which comes after the disease has set in, and these are people really where we've missed early diagnosis, we've missed screening, we've missed early treatment. So here what we're trying to do is to try and help the person obtain their best possible health outcome given this disease. So you're trying to prevent further disability or death, and you're trying to limit physical, psychological, social, and financial impact of disability, therefore improving the quality of life. So this can be done through rehabilitation, which is defined as the retraining of the remaining functions for that person to be in their best state as possible. So there's many kinds of rehabilitation, and as I said, the purpose of it is to try and restore the person to their best possible point that they can reach. So let's have a look at some examples. Medical rehabilitation, this example would be somebody who perhaps has had to have their breast removed as a result of breast cancer. So part of their, part of the rehabilitation might be to have reconstructive surgery. So here you can see they're taking a muscle, flicking it over, putting in some padding. And this, obviously, it's not necessary for the person's physical health, but in order for them to feel normal again or womanly, some women really require this to be able to get back to their normal every patient to see what they want and what will best help them. An example of physical rehabilitation can be perhaps after an injury. Somebody's broken their leg, they haven't been able to walk on it for months, and now they're coming out of the cast and they've got to slowly regain their muscle strength, their balance, etc. Another example is social rehabilitation. In this situation, you might have somebody who's been suffering from a drug addiction. The family oftentimes in that situation is very angry, they blame the person, they think the person is being manipulative intentionally. But once you help the family to understand that addiction is a disease and that actually manipulation is really just part of that disease and doesn't define who the person is, what we see then is a lot more healing happening, and then you've got the family actually supporting the person who has suffered from the disease. Psychological rehabilitation, also very important. We know that depression is very common after strokes, after heart attacks, after being diagnosed with diabetes, for example. And so addressing depression is incredibly important because obviously it improves the person's well-being, but also it's critically important in terms of maintaining adherence to medication. Because somebody, for example, who has HIV, who becomes depressed, often then starts missing their medication. So this is a very important component of rehabilitation. Another example of rehabilitation is economic rehabilitation. So that might involve getting a disability grant for the person. The person might have to learn new kinds of skills in order to get work. And so this would be vocational rehabilitation. So that brings us to the end of the lecture. I hope that you've got a good understanding now of the natural history of disease, the different stages, and how it relates to disease prevention. Thank you very much.